Good morning. I'm Dr. Neema Acharya, Professor and Head Department of Obgy at Dmiher, Jnmc, Varna in India. And today I'll be talking something about assisted vaginal delivery. So the learning objective of today's class are discuss indications and prerequisites of vacuum and forceps use, discuss pelvic landmarks and define the instrument and procedures, explain the A through J mnemonic as it applies to vacuum extraction and forceps delivery. Now we all know that labor is a dynamic event and second stage of labor being the climax of the process. So nearly 4 to 5% of vaginal delivery cases need to be assisted or need assistance either for maternal or fetal reason. The fetal indications being persistent intermediate category 2 or abnormal category 3 fetal heart rate patterns, prolonged second stage of labor, and maternal exhaustion. Assisted vaginal delivery are of two types. One is a vacuum assisted vaginal delivery, and the second one is forceps assisted vaginal delivery. And it's a very important skill for managing second stage of labor, which every obstetrician or a family physician who takes care of obstetrics should be knowing. Now, the rate of assisted vaginal delivery has decreased steadily globally from 9% of live births in 1990 to 3.5% recently. Now, vacuum assisted vaginal deliveries represent almost 2 to 3% of deliveries. It was found that in 2015 it was around 2 to 3%, and forceps delivery almost 0.5%. This change or this difference is mainly because the forceps delivery skill required. Many obstetricians have that fear of causing maternal trauma while applying forceps, and the skill is reducing day by day, and people are preferring more cesarean sections. Now, in 2017, international study found that trainees were equally confident in their skill at hands on assisted vaginal delivery, despite the low numbers of procedures, but lacked skill in determining when to perform assisted vaginal delivery. So maybe we are training them on a simulation mode, or we are training them on live patients, but the problem is they don't feel confident to take that decision, or they don't know when to take that decision, whether this woman needs a assisted vaginal delivery or she should go for a operative delivery. Now in 2014, one of the studies of US hospitals teaching hospitals which was done showed that 3.7% of hospitals did not perform vacuum assisted vaginal deliveries, and 38.3% did not perform forceps deliveries, and they preferred an operative, that is cesarean section. So, can we prevent actually the assisted vaginal deliveries? Assisted vaginal delivery is a procedure with an inherent complications if not done by a skilled person. One is a complication related to the procedure itself, and the other one is if you are not selected the case very well, having the good normal prerequisites and indications. Use of epidural analgesia and dorsal lithotomy position are one of the hindering factors which may, uh, affect the duration of labor, and the decision to deliver by operative delivery will be more. Upright or lateral positions during second stage of labor are little favorable. The continuous presence of labor support companion has been found to be very useful in reducing the assistance in vaginal delivery, and that means having her husband or her, a relative whom she is comfortable with will help her have that mental support while bearing down during the second stage of labor. The use of techniques to increase the effectiveness of maternal efforts during second stage of labor. There are various techniques. Some people may tell her to squat. Some patients may prefer sitting in a sitting position. Some patients may, there is a technique described in a book that two people holding a towel tightly, and the mother is also while pushing, she's holding on to the other end of the towel. There are certain techniques which are followed by many obstetricians. There are railings which can be held on both sides by the mother, and against those railings she can bear down. So there are various techniques which can help her in assisting in the second stage of labor. Oxytocin administration in the second stage of labor is also one of the factors which should be considered specifically if women have opted for epidural analgesia. Now, placing arbitrary limits on the appropriate length of second stage of labor can increase the rate of vaginal delivery. That means arbitrarily one obstetrician feels that it's been 2 hours that she's in labor, she's a primary, I must deliver her. Or arbitrarily it's been more than 1.5 2 hours for a multigravida, and she's been prolonged. They presume that she is in a prolonged labor, and they may go ahead with assisted vaginal delivery. So all these things need to be, there should be a proper protocol, and there should be a proper analysis done by a senior skilled obstetrician before we decide whether she should we should wait, or we should go for a operative or assisted vaginal delivery. The recent guidelines support allowing more time for progress to occur in first and second stages of labor, provided both mother and fetus are doing well. Now, what is assisted vaginal delivery? Assisted vaginal delivery is a method of childbirth where a medical device, that is forceps or ventouse or vacuum, is used to assist the delivery of a baby through the birth canal. This is a kind of definition. Then coming to the purpose, it's used when the second stage of labor is prolonged, or if there are concerns about the baby's well-being or the mother's health. That means the mother is not uh, capable, or she should not be allowed to be bearing down or doing that Valsalva maneuver for a long time in second stage of labor. The types, as we discussed, they are either forceps assisted delivery or a ventouse assisted delivery. Now let's first come to vacuum assisted delivery. Now, early ideas, the concept of using a vacuum start, if you go to the history, it started way back in 17th century, and then gradually as we moved ahead, we found that the modern era, Malmstrom was the scientist who developed the modern Ventouse or Malmstrom extractor, which was a metal cup. Now the materials have improved over the years, and initially made with a metal cup. The design of the Ventouse improved with the use of materials like plastics, and nowadays we have siliconized rubber. So these are the devices which are available, as you can see in the picture. So rigid were there in 1968, as you can see these are rigid cups, and nowadays what you have is this elastic soft cups, and Kiwi Omni cup is recently being used. Now, the indications and prerequisites are well defined. So, the indications being prolonged second stage of labor, the condition of the birthing person compels you. That means the conditions such as the patient is a known case of cardiac disease, a severe anemia, severe preeclampsia, where you don't want her to bear down, and which is going to worsen her medical disorder. So these are the conditions. Or she's too much exhausted. In that case, you need to help her with the delivery and extraction of fetus. Now, persistent category 2 and category 3 tracing is present in cardiotopography, and it is showing you that the baby is going towards hypoxia and acidemia. And as we all know, prolonged second stage. And the table here shows that these are the guidelines which have been given to give you the 95th percentile of the duration of second stage of labor with and without regional anesthesia. So as you can see, nulliparous women can be in second stage for 3 hours with regional, and without regional 3 hours, and with regional almost 4 hours, and multipara 2 hours, and for without with regional it is 3 hours. But always remember that these durations are given provided both the mother and fetus are doing well, and you are monitoring them very well, and you have a tertiary setup where you can shift them for an assisted vaginal delivery or an operative delivery. And if you are in a primary health center, this much time one should not be taking to take decisions. So every case should be individualized as per the setup or the system where you are working, and the fetomaternal condition. Now, epidural analgesia may interfere with the pushing efforts. We all know that. Then, birthing person or the maternal indications, as we discussed, if there is any cardiorespiratory, intracranial disease, or severe hypertension, severe anemia, so we could use forceps or Ventouse. And category 2 and 3 CTG. So these are the category. These are the and this is the way you analyze cardiotopography during labor. So the late decelerations, if you find that the contraction has weaned off, but still the decelerations are persistent, so it's not a good sign. The fetus is not able to cope up the stress of contraction, and they are not able to come out of that hypoxemia which has occurred. So it's a kind of ominous sign, and we should be immediately thinking about taking a decision of uh, extracting the baby as early as possible, and depending upon whether it is for assisted or operative, the obstetrician has to take the decision. Now, the prerequisites for an assisted vaginal delivery. So, conditions that must exist before an assisted vaginal delivery should be attempted. Find out that all these parameters are there and you have verified them. So, it's a vortex presentation with pelvic engagement and position determined. Complete cervical dilatation. The cervix should be fully dilated. The amniotic membranes should be absent. So, if the membranes are bulging, you might as well do rupture of membranes with artificial rupture of membranes. Lack of suspicion of severe cephalopelvic disproportion. So the senior obstetrician or the skilled person is supposed to see if there is any cephalopelvic disproportion. Available shoulder dystocia risk. So if the baby weight is more than 3.8 or 4 kg, be aware of shoulder dystocia and be prepared for it, because the head may come out and there will be turtling of neck, and then we will be in trouble. So the person should be well versed with management of shoulder dystocia as well. Then willingness to abandon the procedure if difficulties occur, including a plan for proceeding for cesarean. That means you must have a cesarean section set up, an OT, an anesthetist, every facility to immediately shift the patient into cesarean section case. So definitions: engagement is defined as the passage of biparietal diameter of the fetal head through plane of inlet. So when we say that clinically engagement, if you do per vaginum examination, there could be different interpretations. For practically, if you see per abdomen, the head should be completely inside the pelvis. It is not palpable at all in the pelvic grips. So it's a sign that the head has gone inside completely. So by definition, clinical evidence of engagement is presence of the leading edge of fetal skull at or below the ischial spines. Now, zero station does not prove engagement, especially with a posterior presentation or a large degree of molding. The head is engaged when neither the sinciput nor the occiput is palpable above the border of symphysis pubis. So, per abdomen examination is a must. Per abdomen obstetric evaluation should be done before we embark on PV examination. What you feel per vaginally at the outlet could be just the caput which is there, and you may get misled, and there could be a moderate or severe degree cephalopelvic disproportion. Now, the choice of whether to use Ventouse or whether to use Forceps. So in United States and globally, you will find that vacuum extractor is more commonly preferred instrument than forceps, because obviously for the ease of use with which it is used, forceps requires a little more skill and also a little more space in the lower genital tract to be applied, and the pelvis needs, there should be some space for forceps blades to enter, and Ventouse is relatively easier to apply. So vacuum assisted vaginal delivery requires clinician to follow the pelvic curve. Less force is applied to the fetal head, although this may be liability with a rapid delivery is indicated. Vacuum extractor use causes less trauma than forceps. Maternal trauma we are talking about, because Ventouse is associated with more with the fetal trauma, or the neonate will have all the consequences later on if it is not done properly. Now, we have this nice mnemonic that is A B C D E F G H I J. So A to J mnemonic, which can help you to follow the steps when we decide that we have taken a decision to apply Ventouse or forceps. Before we go to this mnemonic, always make sure that you have given this choice to the couple, you have given this choice to the laboring woman, and she's agreed to it. You are supposed to take a written consent, document it. So one person should be doing that. So it's a teamwork, and the team should have a scribe, a team should have a lead person who is going to do this. One person should be assessing the fetal heart, one person should be assessing the contractions, and one person should be in communication with the family of the woman to take consent and take it in documentation. So let's move ahead with the mnemonic A to J. A to J. So A is ask for help, address the person, and determine if anesthesia is required. So ask for help. Obviously, if you are alone in a labor room, you are going to call your senior, you are going to call the staff nurse, or you are going to call the any assistant who is also aware of this procedure. Then B is bladder should be empty. So make sure that her bladder is empty. Most of the time in second stage of labor, they may not have passed urine for a long time and even the bladder must be full. So the easiest way to avoid trauma to bladder and bowel that they should be empty. So if you feel that she is not able to pass urine at this stage of labor, then you may catheterize with a simple disposable catheter and make sure that the bladder is empty. The cervix should be fully dilated. There was an error when it was told to us that you can apply Ventouse if she is 6 centimeters and more dilated. But in modern obstetrics, we don't do this. The cervix needs to be fully dilated. Now coming to determine the position. So before position, you must make sure that the membranes are ruptured. If they are not ruptured, you will do low rupture of membranes. Now determine the position, consider shoulder dystocia, review helper mnemonic. So you should be very well versed with the shoulder dystocia management and one should be ready with that also as a next step before we deliver the head. So determine the position, that means where is the fetal head, where is the occiput, where is the lambdoid suture, where is the bregma, am I palpating the bregma, then it could be a deep flexed head. So it should be an occiput should be the leading point. It could be an occipito-posterior or it could be an occipito-anterior. Now, occiput could be at different positions of the maternal quadrants, so making it either a left occipito-anterior or a right occipito-anterior. So you're going to make sure and examine that where is the occiput. There was an era we were using this cup, which was a metal cup. It had a knob over it. So we were making sure that we were having that knob near the occiput, wherever is the occiput, so that when we give traction, the knob also moved. So we knew that the rotation has happened from LOA. It has come in the AP diameter of the outlet. So that was the purpose of knowing the position as well. It's a bit difficult situation if it's an occipito-posterior or an occipito-transverse position, and the traction direction is going to change depending upon whether it is occipito-anterior or occipito-posterior. Now coming to equipment, your equipment should be ready. So you must tell one of your team members to make the equipment or get the equipment ready. The equipment is definitely going to be the delivery tray and the suction pump. There are devices, Ventouse devices, which have their own self-attached suction device, or if it is a simple elastic cup, then you will have to have a tubing and a central suction machine needs to be attached to it. Now coming to F, that is apply the cup over the flexion point. Now feel for vaginal and cervical tissue before applying the suction. So make sure that the vaginal tissue is not coming in the rim of the cup, and make sure that the cervical tissue is also not coming in the rim of the uh, cup, right? And the cup should be more towards the occiput and not towards the bregma. So that is called as pivot point. So point is the point where you are going to apply the cup. If you take the distance between occiput to the bregma, you will have to put from lambdoid suture to bregma. You should put cup more towards occiput. So when you give traction, the occiput is going to come down earlier, and it is going to help in flexion of the head, which will hasten the or help you in the reducing the diameter of head and help you in the delivery of head. Now coming to gentle traction. Now while giving traction, make sure that your one hand is on the ventouse and one thumb is on the ventouse and the fingers are on the fetal scalp, holding it tightly onto the fetal scalp. So gentle traction should be applied steadily and at right angles to the plane of cup. Proper axis traction is the most efficient means of effecting the progress with least amount of force to avoid birth trauma, rocking movements, or you should never make it very, should not be very harsh on pulling the patient down. It should be a very gentle traction. As the fetal head flexes past beneath the symphysis pubis, that means as you can see the head almost near the symphysis, below the symphysis pubis, almost at the outlet, and begins to extend. So as it begins to extend, the vacuum handle will rise from an approximately horizontal position to upright position or a vertical position. Then, when will you halt traction? Halt the procedure entirely if the 12 minutes have passed. Means you've been giving traction, you have been pulling the ventouse, but the baby has not been, you are not able to extract the fetus or the fetal head in 12 minutes. So, this, as I said, somebody keeping the time scribe is very important, who's going to guide you that it's been already 4 minutes, 5 minutes, 7 minutes. It's been more than 12 minutes. It's always advisable to stop the procedure and take the decision of maybe operative delivery. Incision. So if you need to increase the incision of episiotomy, make sure that you have increased the episiotomy. If you have not given episiotomy, give an episiotomy, maybe a left or right lateral. Now J is remove the vacuum cup when the jaw is delivered. So as soon as you see the jaw of the baby coming out of the outlet, you are going to dislodge the suction, stop the suction, and the ventouse cup automatically dislodges from the fetal scalp. Now this was all about the procedure of ventouse. Now the obstetrician should be very well versed with this skill. This A to J mnemonic has been prescribed by uh, the American Association of Family Medicine, and it's a very good mnemonic. And I think it's very easy for students to remember the steps, or new obstetricians to remember these steps, and they are not going to miss anything. So coming to disadvantages of assisted delivery now. The disadvantage of using vacuum devices for assisted vaginal delivery include the delivery is expedited only when there is cooperation from the mother. Proper traction at right angle of the plane needs to be given. The vacuum cup is necessary to avoid losing suction, and there is increase in the incidence of cephalometoma. Now, contraindications to vacuum delivery. Prematurity. You cannot apply the ventouse cup to the scalp of a premature fetus because there is a lot of negative pressure which is applied on the fetal scalp, which cannot be withstood by a preterm baby. It will lead to retinal hemorrhages or tentorial tears. So, all these negative forces on suction forces on the premature fetal head are not advisable and they are almost contraindicated. Now, it is generally considered inappropriate to apply ventouse before 34 weeks of gestation because of the risk of intraventricular hemorrhage. You will not apply ventouse to a non-vortex presentation. That means you are not going to apply it to a face, obviously, face presentation. You are not going to apply it to bro because there is no mechanism of labor in bro, right? Now, incomplete cervical dilatation. Now, application of ventouse without complete cervical dilatation, there is a serious risk of cervical laceration and it's going to cause a lot of traumatic PPH. Now, suspected cephalopelvic disproportion. So, as we know that if the head is generally the dictum is if the head has completely gone inside the pelvis, both occiput, sinciput, both are not palpable per abdomen, and it has entered the pelvis. We presume that the head is engaged and cephalopelvic disproportion is almost uh, ruled out. So make sure that there is no cephalopelvic disproportion. Now, care after ventouse delivery or vacuum delivery. The parent and the newborn should be examined for evidence of birth trauma. Localized caput, formation, or small hematomas can persist. So, cephalometoma generally comes up in the next 24 hours. The caput, you will see that the caput is there at birth and it disappears after 24 hours. It's a edema of the scalp, of the fetal scalp. Now, when cephalomatomas will generally appear after 24 hours, so they will not cross the they will not cross the suture lines of the fetal head. So make sure that there is no you examine the newborn the next day for any cephalomatomas, right? And they should be, if they have cephalomatomas, now they become high risk for hyperbilirubinemia also. So make sure that these babies are monitored for at least a week if you have applied a ventouse. Now coming to forceps assisted delivery. Now forceps delivery, Simpson's forceps, it consists of two interlocking leaves, as you can see, which are referred to as right and left according to the side of pelvis to which they are applied. Now each leaf has a handle as seen in the diagram, a shank, a lock and a blade. The blades are curved on the inner medial side, producing the cephalic curve. So these two leaves, so these two are cephalic curves. And then there is a curve which goes like this, so that is called as a pelvic curve. So the pair of forceps has a cephalic curve and a pelvic curve. Now, the forceps have been divided into outlet forceps, low forceps, mid forceps, and rotation forceps. So, let's come to outlet forceps. The fetal skull has reached the pelvic floor. So, these are the prerequisites where you can say that this is a level, or these are the levels of pelvis, various levels of pelvic planes where the fetal head has reached, and that is the level you are going to apply the forceps. So, outlet forceps and low forceps are uh, still followed in modern obstetrics. The mid and rotation forceps have almost become obsolete in modern obstetric practice. So, coming to outlet forceps, the fetal skull has reached the pelvic floor and the fetal head is at or on the perineum. The leading point of fetal skull is more than 2 centimeters from ischial spines. As practically, if you ask me, the fetal scalp is almost visible on the vulva, practically. The scalp is visible between the contractions without labia being separated. So, without contraction, also, the head does not recede back in the vagina. It is so much outside, almost on the outlet. The sagittal suture is in the anterior posterior diameter or in the right or left occiput anterior position, but not there is the deviation of the this thing. Either it is left occipito anterior and right occipito anterior. It's not occipito transverse. So it has to be within 45 degrees of the AP diameter of the outlet. Now coming to low forceps. The leading point of the fetal skull is 2 centimeters from ischial spines. The head is not on the pelvic floor. So mid and rotation forceps, I will not go into details because these are almost obsolete in modern obstetrics. The head is high above, that means almost at zero or station or above, and at that stage we don't apply forceps. Now coming to the mnemonic A to J, even in forceps. So again, we all know that ask for help. So your team is going to be ready. You will have a obstetrician skilled. You will have an assistant. You will have a scribe who will keep the time and who will keep the record of contractions, fetal heart rate. Then you will have a person who's going to talk to the family, to the couple, explain the procedure, take consent, and so this is a team. You are going to inform the neonatologist also to come and attend the baby. Now bladder should be empty. B for bladder. C, cervix should be fully dilated. D, determine the position. As we know that it should be, just now we described, it should be almost on the vulva. The suture of the vertical suture of the sagittal suture of the fetal head should be within 45 degrees of AP diameter of outlet, or it should be in the AP diameter of the outlet. Now equipment, these are the equipments which are there on a delivery tray. So you're going to have a pair of additional forceps for delivery. Now forceps should be ready. Many physicians will coat the forceps blade with surgical lubricant. So generally what we use is we can use a little bit of normal saline, we can use a little bit of antiseptic solution, but preferably use a normal saline or liquid paraffin because otherwise those antiseptic solutions could harm baby's eyes. Now G is for gentle traction. Now these are the images which show you how we are going to apply the forceps. Now always remember that if it is a left occipito anterior position, that means the occiput is within the 45 degrees of the left side of maternal outlet. In that case, you are going to apply the left blade first because this blade is going to make sure that it rotates to AP diameter. Once you put it, it acts like a vectis also. It helps you to rotate the head and get it into AP diameter of outlet. So if it's a right occipito anterior position, you will apply the right blade first. This is a protocol which is followed, right? So see now how each blade is held. So once you have decided, you have taken consent, you have made sure that there is no CPD, you are going to start, you have checked all the prerequisites, you are going to align the forceps and make sure that the blades belong to the same pair. right? So once you have aligned it, you are going to decide left or right to be applied first. So you take the first blade. So if you are going to apply the left blade to, it will go to the left side of the maternal pelvis. You are going to hold it like a pencil or a pen on in the left side. So obstetrician holds it in the left side and it goes to the left side of maternal pelvis. Now when you put it inside the pelvis, you are going to put your opposite hand, that is the right hand. If you're going to apply the left blade, I'm holding it in the left side, left hand, and then I'm going to put my right hand below the fetal head in the vagina, and I'm going to make space for this forceps blade to be entering the vagina posteriorly first, and then you will take it to the left side of maternal pelvis. Once that is done, one assistant will hold this blade in one in that position. Otherwise, it will again fall back down towards the posterior side. So that side it has to be held by one assistant ideally. Then the other blade is put again in a similar fashion. I'm going to hold it in the hand, the right hand. The left hand will guide it posterior through the posterior vaginal wall, and then I will put it to the right side of maternal pelvis. Now, if they are applied, if the case selection is proper, the blades will apply easily. You will have enough space for blades to apply, and they will lock easily. Now, once they are locked, you know, it is confirmed that your selection of case was good, it was right, and the blades are applied in a proper cephalic and a proper pelvic curve. Now, these are the images which show you how they are applied. Now next is evaluate for incision for episiotomy. So if you have not given episiotomy, give it. If it is, it will increase the space and avoid the trauma. And second thing is if it is given, review whether you need to increase the incision. Now coming to J is remove the forceps once the jaw is reachable. So before we remove it, you should know what is the direction of the um, pull, right? So the direction of pull is always along the curve of pelvis. So it's going to be always either little bit downwards if the head is still not below symphysis pubis. So you're going to pull it in a downward direction. Then it comes below symphysis pubis. You're going to extract it in a forward direction. And once it is almost outside the symphysis pubis, you're going to elevate it uh, in a vertical direction. So it goes like a J shaped or a C shape, and it is along the pelvic curve as you can see it in the diagram, right? Now, rotational assisted vaginal delivery is often regarded as a potentially unsafe practice that we have already seen. So, mid and rotational forceps are not practiced in modern obstetrics. Now, once the baby is delivered, you remove both the blades, and as we all know, we should be ready for shoulder dystocia, and the helper mnemonic should be known to everyone, and we should be prepared for that. Once the blades are removed, you will deliver the baby as usual, and then make sure that the baby is delivered fully. You will do delayed cord clamping if baby is having any signs of the Abgar scores are little are on the lower side, 1 minute, 3 minutes, then you are going to do early cord clamping and ship the baby to neonatologist for further care. Now, care after delivery, you must rule out maternal lower genital tract lacerations uh, because there could be vaginal, there could be tears in the genital tract, lower genital tract specifically. There could be perineal tears, the episiotomy could extend, right? So, rule out postpartum hemorrhage. Then, newborn birth trauma. Newborns often have visible forceps marks. The parents are a little apprehensive, immediately after delivery. There is a mark on the fetal scalp, specifically in the temporal area, so they are a little apprehensive, but you must tell them that these marks will disappear in a couple of days and there is nothing to worry. Now, these are the few images which I would like to show you what is a caput, what is a cephalometoma, right? So, as you can see, edema, that is a caput, is a edema, it is a physiological edema of the fetal head because it is compressed in the soft tissues like cervix during the process of labor and in the bony passage, that is the bones, pelvic bones. And there is a edema of scalp. But this edema it is there at birth and it disappears after 24 hours and it always crosses the suture lines of the fetal head. And the cephalometoma, it comes after 24 hours. It is evident in the next few hours or at 24 hours, and you will see it's a tender swelling. The the neonate cries if you palpate it, and it does not cross the suture line because it is subperiosteal hemorrhage. And as you can see in the image, there is a subglial hemorrhage. It's a very serious this thing. Neonate can get into these hematomas if the delivery has not been selected properly and there was a lot of force which was used. Now, how much force one should uh, apply while extracting in forceps? So it is said that if it is generally 16 kgs per meter square to put it in numbers. But practically, if you ask me, you're supposed to, a robust obstetrician, a muscular obstetrician should sit down and making sure that only forearm muscle strength is used to extract the baby, right? So that inadvertent force is not used while delivering by forceps. Now, shoulder dystocia is a threat which is there in all difficult labors because uh, you are going to deliver the head by either a ventouse or a forceps, but then the shoulders may uh, get arrested, and one should be very well versed with how to deal with shoulder dystocia. Now, the maternal risks associated with vaginal delivery, we all know that there could be trauma, which will make the patient high risk for postpartum hemorrhage. So there is a high risk of blood transfusion later on endometritis, and then obviously if the procedure fails, she will be going for cesarean sections. Apart from vaginal lacerations, perineal lacerations can also be there. Anal sphincter injuries are also one of the risk factors if these are not selected and performed well. The station at which the assisted vaginal delivery is performed has no known effect on the urinary or anal incontinence. That is what the evidence says. Then there is a preliminary evidence from retrospective cohort studies that mediolateral episiotomy may be protective in preventing obstetric anal sphincter injuries. So specifically, in assisted vaginal delivery, it's always advisable to make an incision. So in A2J mnemonic, you have a letter I meant for that. So if you have not given episiotomy, please consider giving a mediolateral episiotomy and prefer mediolateral rather than median because it may get extended into anal sphincter. Now, these are the recommendations which say that what are the guidelines which should be followed while delivering them, either assisted vaginal delivery or whether to use epidural analgesia or not, and what happens if you use epidural analgesia. Now, the predictors of success and failure of assisted vaginal delivery: less than 1% of Ventouse assisted vaginal deliveries are unsuccessful. Now, factors associated with failure, they are nulliparity, white race, induction of labor, chorioamnionitis. Patient has been leaking for a long time. Patient's liquor, the liquor has been drained completely. So these are all high risk factors. Occipito-posterior position, uh, fetal weight is more. Obviously, if it's a large fetus, gestational age is more. Like she's crossed 40 weeks. If you've used epidural analgesia, or mother has been completely exhausted, so there is no bearing down effort. So these are all factors which can increase the failure rate of assisted vaginal delivery. Now, after all this, let us come to this one or two scenarios where ventouse or forceps deliveries could be an indication. Now, coming to the first case, she is 28-year-old. She is second gravida, first para. The gestational age is 39 weeks and 5 days. There is no history of any medical comorbid conditions, and previous was a vaginal delivery, and there was no complication in that. Current pregnancy is uncomplicated, and she has gone into labor spontaneously. So now this patient, she presents to the labor ward at 39 weeks 5 days with regular contraction. She has been in active labor for almost 8 hours, and vaginal examination reveals that the cervix is fully dilated, station is +2, it's a cephalic presentation, occipito anterior position. There is mild molding and caput which is there, and despite effective maternal pushing for the last 1 hour almost, there is minimal fetal descent, and cardiotocography monitoring shows fetal heart rate of 165 beats per minute, and variable decelerations are noted. So it comes to almost like category 2, right? It could suggest a cord compression or maybe compromising or fetus going towards compromise. Now, what do? We take a decision of Ventouse delivery. So the attending obstetrician decides to proceed with Ventouse delivery based on the following indications. So in this particular case, it's a prolonged second stage of labor. As per guidelines, prolonged second stage, if the mother has been more than 1 hour in multiparous woman, is an indication for assisted delivery. But as we all discussed, there are uh, with and without epidural analgesia, we saw what are the limits which have been given. But in this particular case, mother was also exhausted, so she was fatigued. So that is one of the points where she could not have been able to push and get the baby out. And non-reassuring fetal heart tracing was also there because there were variable deceleration suggesting there is some cord compression which is happening. Now, steps to be taken. Explain the procedure, risks, benefits. As I said, you must have a team of skilled birth attendant team like scribe and assistant, a neonatologist, a person who is going to go and talk to the relatives, a birthing companion. So all these people are going to act together. So you're going to, after this, you're going to follow the A to J mnemonic, deliver the baby, be prepared for shoulder dystocia, and once the baby is out, make sure that you do clamp or clamping. Take steps to prevent postpartum hemorrhage. That means you're going to use oxytocin in the third stage of labor, and then evaluate the newborn for APGAR score, evaluate the mother for any perineal trauma or PPH. So the conclusion is the case highlights the use of Ventouse delivery in cases of prolonged second stage of labor, maternal exhaustion, and fetal distress, ensuring a safe outcome for both mother and baby. Now, coming to a second case, she is 32-year-old, primary gravida, and she is 40 weeks and 2 days. And medical history, there is no significant medical past history. And current pregnancy is uncomplicated and spontaneous onset of labor she came with. So she progressed well through the first stage of labor and she reached full cervical dilatation after 2.5 hours of active pushing. Uh, she's been pushing, say, almost last 2.5 hours, being a primary gravida. Fetal head was visible at perineum, almost at the vulva. The previous case, as you can remember, it was a plus two station, a little higher up. It was not at the outlet, and the mother was exhausted. There were variable decelerations. Now, in this case, note that the fetal head is almost at the perineum, and station is +5. That means almost at outlet. And occiput on anterior position. There is no caput or excessive molding. The cardiotocography shows here now the baseline heart rate is 145 and the late decelerations are noted, indicating potential distress. Now, this woman is also exhausted with prolonged pushing, and there is an ominous sign of late decelerations in the CTG. So, despite strong maternal efforts, the baby is not delivered spontaneously. So, the obstetrician decides to proceed with outlet forceps assisted vaginal delivery based on the following indications. So, we all know the indications now. There is a definite maternal indication, she is exhausted, and there is a very much indication from fetal side, that is late decelerations, right? So favorable conditions in this patient, particularly for forceps delivery, we all know that it's an occipito anterior. The station is +5, right? So it should be very, very low down to deliver any patient by forceps delivery. And practically, if you ask me, with my personal experience, what I have understood is there should be enough space for the blades to go inside. So at least make a PV and make sure circumferentially around the fetal head there is some space in the vagina that both sides you will be able to apply and put the blades inside and not forcing them inside, causing vaginal trauma, perineal trauma, or even rupture of uterus. So it's a very a skilled person can take, or an experienced person should take the decision of forceps delivery. Now, steps to be taken again, the explain the procedure, take the consent, follow A to J mnemonic, evaluate the newborn, and you evaluate for PPH, specifically cervical lacerations. Any atonic PPH also could also be associated with this, and we all know lower genital tract lacerations can also be there. Now, conclusion, the case highlights the use of outlet forceps delivery in cases of prolonged second stage of labor, maternal exhaustion, fetal distress, ensuring a safe outcome for both mother and baby. So, coming to the summary of this lecture, the assisted vaginal delivery via Ventouse device or forceps is an important skill for managing the second stage of labor. Labor is a dynamic event, and emergent or elective assisted delivery may be required for indications like category 2 and category 3 tracings of CTG in labor. Situations that necessitate immediate and competent use of ventouse delivery or forceps can arise quickly, and they are emergent situations, and uh, they may arise in low risk labor. So one should be skilled and trained. Skilled birth attendants in all communities should learn how to provide assisted vaginal delivery. Performing assisted vaginal delivery when appropriate may have a significant role in preventing cesarean sections, and we can reduce the cesarean section rate and thereby the burden on the healthcare system. Then simulation programs can assist in developing and maintaining the manual skill required. So we must practice training our students, postgraduate students or clinicians uh, on simulation mode, how to conduct forceps or a ventouse delivery, and drills should be regularly performed for the teamwork which is required for these emergency situations. Thank you so much, and these are the references which I have used. Um, we will make a separate video for the actual procedure of ventouse and forceps to be followed. So we we will show actually how it is done on a simulation mode in our next lectures. Thank you so much.